Okay, we're recording. Round of applause, y'all. You're 2 weeks in.
Everyone's like, is he serious? And everyone's like, I don't know, do I actually clap?
Yeah, you clap. Heck yeah, you do. You made it 2 weeks. You're here. Heck yeah. All right, welcome, y'all. I know you've been at it for a couple of weeks, but this is the first time we're seeing you face to face, other than some of the assignments. So it's good to meet y'all. What tonight will look like is some general introductions, just so you know us, me, Christina, Alex. Julie's not on this call, but you'll get to know her. She's already commented on some of your all's assignments. So introductions, and typically what these meetings will look like is we'll go through some general themes that we may see in the assignments. Some are more dense than others. Like, the first 2 weeks, the assignments weren't anything crazy, right? Like the tug challenge was more just for fun, getting you used to being filmed, a little bit of competition, right? Week 2 was relatively straightforward. They'll get a little more complex as we progress. And so Alex and Julie will break down some of those themes, and we'll have some discussions around there then. And then we like to save some time for the student questions, which, my goodness, y'all, we were talking awesome questions, right, Christina?
Yeah, amazing. I love how engaged you all are already, and we haven't even gotten on the call. So super exciting. We were going through making sure that we had everything prepped to make sure we can answer everything for you today.
Yeah. Okay, awesome. Christina already pasted that. I'm gonna have a tough time keeping up with this chat. So that's a good problem to have. 29 folks on our first call is pretty awesome. All right, so that's what it looked like. We make sure that we're respectful of your time, so we will not go much past 9 p.m. Eastern Standard Time. So you can always kind of account for an hour there. All right, Christina, who are you?
Hello, everyone. My name is Christina Previtt. I am lead faculty with Dustin for Modern Management of the Older Adult. You may also see me with pregnancy and postpartum on ICE. I teach the clinical management of the fitness athlete pregnancy and postpartum course with Alexis Morgan. Some of you in here have actually taken that course. So it always gives me such joy that you can, even in very different areas of practice that I see you in both courses, it always makes my heart so happy. A little bit about me. I am up in Kingston, Ontario, Canada. We are in full lockdown right now, so I'm on pretty much house arrest. I have been a clinician for about 8 years now. I own a physiotherapy clinic called Stave Off Physiotherapy, which we have actually just closed for me to transition down and immigrate down to the US. My role with ICE has grown so much that Jeff Moore is like, all right, we need to get you down here. So I'm going to be moving with my family to Charlotte, North Carolina, hopefully by the end of this year. I started Stave Off because I really felt that we needed to have this bridge between physiotherapy and wellness, and specifically in regard to the older adult. I created programs at Stave Off that were specifically geared towards helping individuals remove barriers to exercise, whether that be through one-on-one rehab or through group fitness. And that was based off my PhD. So I am currently writing my dissertation on the use of high intensity resistance training for transitions in mobility states for older adults. So I am looking at individuals with frailty and mobility disability that you all see probably all the time in your practice. And I have looked at the safety and feasibility of doing some barbell training, which is exactly what we teach in this course. Spoiler, it's safe and it's feasible. So I'm just currently finishing up writing my dissertation, and I'm hoping to defend in the fall. On the personal side of things, I am a competitive weightlifter for exercise. Not competitively weightlifting right now. I am 25 weeks pregnant with baby 2, and I have a daughter who just turned 2. So super, super exciting. My life is crazy busy. I have 3 dogs, 2 cats, 10 chickens. So my life is never boring. And that's a little bit about me.
How many chickens do you have now?
I have 10.
Yeah.
I had a massacre of 5 chickens. If you guys want to hear that story one time after 9 o'clock, I'll tell you my 4 or 5 massacre story.
Yeah, the population is in flux up at the Previtt household.
Not lately. You're making it seem like I'm butchering chickens.
Yeah. Awesome. All right, good stuff. So also let's Go put your Instagram handle in there if you don't mind, Christina. Paste your link in there. So yeah, make sure you give Christine a follow if you don't already. Awesome content, whether it's Jerry related or pregnancy postpartum related. Yeah, go ahead and hit on that. So my name's Dustin Jones. I'm in Lexington, Kentucky. We have any Kentuckians in here? Oh my goodness. Kelly, type in the chat box whereabouts you are in the lovely Commonwealth. So I'm in Lexington. I am a PT of about 10 years now. So I was kind of the typical student that wanted to do outpatient ortho, did the ATC athletic training, certified athletic trainer, did the CSCS. So was kind of primed to want to work with athletic teams. And I took kind of the typical outpatient job, worked with a lot of runners, and I was in a spot that I thought that I wanted to be in for a long time. And then found myself in a skilled nursing facility. Y'all heard about that embarrassing story, right? I think it was the first lecture. Basically a low point of my career. Did not want to be in a skilled nursing facility. I was taking a travel contract in Romney, West Virginia. If anyone is not familiar with Romney, who celebrates Mother's Day in here? Yeah, you're welcome. Romney is where Mother's Day was created and started. But that setting of just kind of coming from the outpatient arena and working with more active and athletic individuals really helped inform how I was working with those folks in the skilled nursing facility. And granted, I had no clue what I was doing and made a ton of mistakes, but it was very informative to see how these folks responded to that type of stimulus. And I became hooked, and then moved to Columbus, Ohio, to do home health. And that home health arena just really shaped my perspective of older adults. And I think the biggest thing that I learned, that many of you all type in the chat box kind of what setting you're in, so we know. Typically we have a lot of home healthers in here, but the home health setting related to the older adult patient helped me see all the different ways that we can impact someone's life, whether it is exercise prescription, whether it is improving their symptoms, reducing irritability, or reconciling their medications, or trying to have some type of home environmental modification that could dramatically impact their life. That really changed my whole perspective from there. So in that time period, started a podcast called Senior Rehab Project that's kind of shaped, taken different shapes over the years. Now it's just Jerry on Ice that we're all a part of. David is on here. I remember reading his stuff early on and just trying to talk to different folks in our field to learn more. And that's how I connected with Christina. And we started teaching this course. So now I'm mainly focused on building a community-based fitness program. So similar to what Christina was doing early on in her career, I'm doing a community-based fitness program within an existing CrossFit facility. It's called Stronger Life. I'm doing that with with a TA within the MOA division, Jeff Musgrave. And that's been awesome. I don't recommend starting anything like that right at the beginning of a global pandemic. Rather difficult. But now that kind of getting out of that mess, just learning a ton and really enjoying that and sharing lots of lessons and mistakes with y'all as well. So that's kind of where I'm at right now. From the family stuff, we just had a baby boy. So we've got a girl that's 2.5, and then Wes is 7 or 8 weeks old now. So as you can imagine, I have no freaking clue what's going on. I forget to brush my teeth most days. Life is an absolute mess right now, but we're here. All right. We're here and we're having a good time. Christina's going to know what that feels like here pretty soon in the fall.
This is like the least stressful hour of your week.
Oh my gosh. I know what to expect here. I love it. All right. Alex Germano.
Yeah. I am physical therapist in Annapolis, Maryland, doing outpatient on wheels with Fox Rehabilitation. Some of you may be familiar with that practice model, but yeah, just providing outpatient services to people in their homes. It's awesome. I have an 11-year history with CrossFit and CrossFit coaching. I started that when I was in high school, so I've been doing it for quite a while, and met Dustin and Christina during one of their first or second or third maybe cohorts of this class online after listening to Dustin on the Senior Rehab podcast. And then I ended up here a few years later, just helping them out with these courses. So you can catch me sometimes with them live, mostly here online. I own Dachshunds. I love donuts. That's basically it.
Can we get a shot?
Yeah,
of the-
Izzy? Lemon? Here, Izzy's here. That's Izzy. She'll be
Man.
next to me most of the time. Lemon's over there. Lemon's the Instagram famous star, but now they both are. So
Yeah, they both. We gotta someone drop that
they both
Instagram
are.
handle in there. That's if you love the dog accounts, you can't go wrong there. You've been
Yeah.
starting to post a little more.
Yeah,
I
they're
appreciate
coming
that.
back. So
All right, good stuff. So that is Alex. You will also meet Julie Brower. Julie, you'll meet her on the next unit discussion. She is a PT in Charlotte, North Carolina. She's got some experience in outpatient, also in acute care. So any of you all that follow Julie, you've probably seen a lot of her acute care content. But she's been doing a great job of kind of applying this to in a setting that we haven't necessarily spoken to too much, and that's the acute setting. You'll hear more about her. Awesome individual, and she's also the director of wellness for, I forget what it was called, but she just took a new position. But she can tell y'all about that. All right, so that's Julie. So let's get into the assignments. Alex, who was our champion?
Wendy with a score of 3.5 seconds. Wendy is the winner of the challenge.
3.5.
You all were really
Wow,
nice.
I'm driving right now, but yay.
Both hands on the wheel, Wendy.
We've had some people get pretty like competitive around the rules and stuff. I don't think that was happening, or at least I didn't see it. Alex, was I mistaken?
No, people were pretty good. Some people were more competitive than others. I feel like it's been pretty chill lately, though.
Yeah, that's awesome.
Good deal. Yeah, the last cohort got a little nasty, I would say. There was someone that did a tug in cross country skis, but lots of people calling each other out, saying they were running or both feet didn't go past the line. So y'all are a little more cordial, which is good. Y'all play well together. All right, so yeah, good job, Wendy. You don't win anything except our respect. So congrats. Now, week 2 assignment, objective measures. Let's talk about some of those themes. Alex will share kind of her thoughts, some questions on, we had a question in the student document as well. And we'll probably dig into some of the measures. There was some questions related to more week 2 type stuff. And then we'll probably shift gears and speak more the questions at the top of the student doc that talked about kind of buy-in from the patient standpoint, buy-in from your team standpoint. Super important questions, right? But let's get into some of the nitty-gritty of the measures in the assessment type piece, and then we'll get into that. So let Alex take it away from here.
Yeah, in terms of measures, SPPBs were looking real good. They are just everyone making sure that semi-tandem is a true semi-tandem with heel next to big toe. Sometimes people step into like a stride stance instead. So that one's just like a make sure that you've got it. You can do the gait measurement twice and get the fastest score from the 2 of those. You can also consider that. But yeah, overall SPPBs were looking good, Dustin. Did you want me to chat about any
that
questions?
tug question would be
the tug question.
Yeah,
perfect.
as well.
Okay, so somebody had a good question about the tug, because I think this was something that was going on within the group as I'm literally scrolling past it 13 times. So the question was, do we need to have the back of the chair touching, or sorry, the back touching the back of the chair before stopping the timer? Or does the buttocks just need to touch the chair when we stop the timer? So they had some other questions about the chair being freestanding versus against a wall. I've heard a million different things. What do we do when we don't have just a regular old chair and like I don't feel very safe with it in the middle of the room? So let's talk about standards first. And y'all made me read a paper from 1991, so that was fun. I went back to the original tug paper, which is probably what the rest of the research is based off of, because it was the original instructions for the tug. So I would assume that the rest of the research is based around that. You can find that paper and the rest of the papers on the Shirley Ryan Ability Lab. It used to be rehab measures. It's not rehab measures anymore. It's Shirley Ryan, but you can look there for really good details and papers regarding this. So in 1991, here's what they said. You need to have the person sitting in a chair. They did not specify in that article if the chair was freestanding in the middle of the room or if it is against the wall. I think now we've assumed that it's just kind of in the middle of the room and not backed up against the wall, but Christina might know the details of this research better, but they did not specify. So we don't know. So that's one thing. And we'll talk about what we do when we don't know. But so we don't know for sure about that one. However, they are supposed to stand, walk across a line, turn at the line, come back, sit down. When their butt touches the chair, that's when the timer stops. They don't need to have their back then all the way against the chair. Timer starts when you say start. Timer stops when they get back into the chair. Okay, so biggest thing is consistency, right? Consistency is key. I don't know if these measurements were performed with the chair against the wall. However, if I do at the same time every time, I can assume that my measurements are valid and that the person is making progress as long as I'm not switching things up a million times. If I want to compare to normative values, norms are important because we base fall risk, et cetera, off of what somebody scores on a tug, for instance. And yes, if a patient is, for me, example is I'm in the home, there's never a 46, I think it's 46 centimeter standard chair around. I don't even have a chair in my house with arms on it. So like I walk into houses like this all the time. The biggest deal is that I know exactly what chair the person started from. And I write that down so that anyone who does the test after me, including myself, because I don't even know I don't know if I can't even remember visit to visit, sorry, what I'm doing. Make sure you write that stuff down so that you can perform it consistently time and time again. I know that sounds silly and it probably is something that y'all are doing, but if we want to compare to normative values, then we need the standard chair, et cetera. We can like loosely compare the number that we get to the number that the research is dictating is like that falls risk, but it's hard to directly compare when we have a very different chair, like it's really low, it's a recliner, it's like rocking and rolling. It's really tough to compare to the norms. However, it's good information for us nonetheless. Questions, comments, concerns?
Does that make sense to everybody about why that is really important, a really important distinguishing point that can sometimes be forgotten? So when we are doing normative data, when we are doing statistics, we are taking a group of individuals and putting them through an absolutely identical protocol. Because it's identical, we can now apply statistics across a homogeneous data set that is going to give us a prognostic factor, for example, for falls risk based on this outcome, or it doesn't. Like that's what we're studying when we're looking at outcome measure validity and reliability. Everybody's favorite paper is to read, right? But when we don't use that, we can artificially inflate or deflate that number and be making a judgment on a person's prognosis that might be inaccurate. And that is clinically very relevant. So a perfect example is the cone, right? Like if you are doing a pivot versus you are navigating around a cone, it is very easy for you to add 4 or 5 seconds. If you have somebody who's on the cusp of the tug, like at that 12-second mark, probably a lot of you who are in home health, but you're not usually at that mark, but if you are, and you use a cone and now you push them to 15 seconds, you've now identified them as a falls risk, where if you used a line, they may not have hit that barrier. So it's really, really important for us to be thinking about those things. But also clinically, we're not always going to have ideal scenarios. And what that means is just exactly what Alex said, is we need to be reproducing the exact same thing, even for our own outcomes, because I know a lot of reimbursements now are based on some of these outcome measure improvements. If you aren't documenting everything that you're doing in terms of how you're doing it, or thinking that you're going to remember, and it changes, you may not see the actual improvement that's there. And you don't want to do that because you're selling yourself short. So just things to really consider as a good reminder for a lot of you. And you're probably, just like Alex said, you're probably already doing it. But it's just my geeky research hat comes on when it comes to making sure that we're stating what we actually can based on what the research is saying. So it's really important to make those distinguishing kind of characteristics between those two things.
have a quick question about the standardization of the testing. So things like the Berg balance scale or the DGI, which has like specific instructions, like sometimes I'll hear people say one direction one way and like it'll be different than like the actual form. Are you supposed to say like exactly what's on the sheet, and then if someone asks you something, like just repeat that same thing without like almost robotically?
Technically, yes. Because we have even shown for things like the 6-minute walk test, the amount of times you encourage a person can skew their results. So if you are encouraging them once at the the baseline assessment, and then you're encouraging them the entire time because now you have more of a therapeutic alliance, you're getting to know them better, you're chatting with them. Now you're adding encouragement, which might speed a person up because they know they're being evaluated. And now they know you and they like you. And you're also potentially adding more dual tasks. So now you're potentially adding a cognitive load to an aerobic outcome measure. And so those types of things, like a 6-minute walk test, like when I did it for my research study and I told my people who are evaluating they couldn't talk the entire time, or we
That's
gave
painful.
scripted responses, it's painful. It is so painful. That is the true marker for the test, because you want to see that's a usual gait speed. I'm going to get into a whole tangent, but you're trying to see what a person does in their community, not when they're being tested. They know that eyes are on them. So if you're continuing to engage them, then you're reminding them that you're evaluating. So just things like that can be really important. So yeah, the SPPB2 has a script. The mini best has a script. And technically you're supposed to say it exactly that way. Is that what happens in clinical practice? Likely not, but we go with it ish. But just in terms of what the research is saying, that's an important distinguishing factor.
Gotcha, makes sense. Thank you.
You're welcome.
Raise your hand if you have a tough time deciding which measure to use with your patients. Yeah, 100%. That will go away. All right. Especially if you're relatively new to the Jerry kind of PT outcome measures, especially being relatively new to them, it is a lot. It's very overwhelming. But the more that you are leveraging these, you are going to get a very good sense of who may be appropriate. So you mentioned the Berg, David. So that's a great example in terms of like in the home health setting, the Berg, that's probably going to be pretty appropriate, right? I may have someone that maybe upper 20s to upper 30s. It's a pretty common score out of 56. That's going to give me some information. It can, be helpful in combination with some other measures and screens to really get a good picture of their capacity and their risk of falling. But let's say Christina's working with someone, a relatively high level individual. Let's say they're like a master's athlete. They're in, let's say they're 75, 80 years old, and you're going to screen for fall risk. What do you think they're going to do to the Berg? What's their score going to be? Probably big old 56 out of 56. They're probably going to ceiling it out. And so she may do something like the mini best test, for example. So the more that you do these, you're going to know, all right, this particular measure is going to be appropriate for this person. But I wouldn't feel too much pressure on that to like nail the one outcome measure that's going to be perfect for this individual, because when you administer these kind of in a clustered format, or you're doing a few of these, that is going to help gather some valuable information that can maybe help out in terms of a particular weakness of a measure that you did pick. So these in isolation, many of these measures in isolation in of themselves may not necessarily be that helpful. That number may not necessarily be as valuable. But when you throw in a grip strength, a tug, gait speed, SPPB, when you combine these all together, that can paint a very solid picture of someone's capacity and their risk of a potential fall, functional decline, risk for rehospitalization, all those fun things that those measures can predict. But don't take that to say, I need to do 8 outcome measures. We're not saying that. As much as necessary, as little as possible. But typically we're not doing these in isolation. Anything to add there?
Yeah, the kind of going on the gait speed measure. So a lot of times we try and combine as many things as possible, right? And so we want to try and make sure that we're pretty well versed in the different outcome measures so that we can slide scales up and down. But there are gonna be certain outcome measures where we're gonna try and double up and we can't. And one of them that tends to happen is using the SPPB and then taking the gait speed and turning it into a gait speed assessment. And that is inappropriate to do. Can somebody tell me why that would be an inappropriate combination of outcome measures to do?
Would it be because when you're on the SPPB, you're not giving the time to like the beginning and end time? I can't come up with words right now, but you're just time, you're saying go and they're going from a stop position, you know, and then not having the warm up cool down. I'm not saying anything's right, but you get it. Yeah.
Yes. So in a gait speed measure, you need an acceleration and deceleration zone that is set up to be calculated so that you aren't artificially inflating or deflating your numbers by not allowing for that acceleration time. Also, if people are looking for a line, they're going to start slowing down in anticipation of that line, which is why in a true gait speed, there's a zone that you calculate the gait speed, and then the line that they're actually trying to decelerate to is further away from when you stop the measurement. So those are going to be really important things because, again, we use gait speed so much and it's so predictive that we want to make sure that we're really classifying our clients well. So we want to make sure that we are capturing a true usual gait speed where we are allowing them that time on each side, or a fast gait speed, same thing, for them to be able to react and navigate around whatever environment that you have them continuing the outcome measure with. That's okay, Wendy. That is why we are doing this right now, is to just talk about those things, because sometimes we get into these patterns and we have to we just have to kind of remember different nuances. I'm in research. It's all about the nuance.
Who, raise your hand if you've kind of struggled with measures for some of your patients that may not be as ambulatory. Yeah. Does anyone want to unmute and mention any ones that you leverage in your practice? That was a question in the student document. We'll talk more about that, but I'd love to hear your all's thoughts of some things that you have leveraged to try and get an objective measure or to demonstrate change.
In acute care, I leverage like either 5 times sit to stand or 30 seconds sit to stand, like all the time. That's like the big one. Gait, it's just like distance, like how far, and assistant based, but no outcome measure.
Yeah. Yeah, those are definitely pretty common. But man, yeah, if someone can't do any of those, you can't pull the 5 times sit to stand or some of those gait assessments. Any ideas, any other thoughts?
I have some patients that are bedbound and can only sit at the edge of the bed. And so I will sometimes do the functional reach, just how far they can sit up out of their base of support, or just timed how long they can sit unsupported.
Yeah, that brings up a great point. And if someone could drop that functional reach test link in the chat box, that'd be great if someone's on rehab measures already. But that's a very good point, Rosemary, because you may not have, there are some outcome measures that we can leverage. I was someone in that particular situation, but you can definitely kind of create your own. Now, back to Christina's conversation of being able to get a particular measurement, objective measure of whatever that may be, and say that it predicts blah, blah, blah. We can't say that, right? We also can't say what is meaningful change, what's going to be clinically meaningful in terms of the progress that they've made. However, when we're able to get that measure, and then if we're able to retest, now granted in acute care, that can be tough, right? Sometimes, with people getting pushed out the door, basically nowadays, that you may not be able to see that person again, but you could kind of make your own objective measure to where you test, you do your treatment, and then maybe in a week, 2 weeks, 4 weeks, whenever you're doing your reassessment, to retest that again. And you can make that a big deal, especially if it's something related to what they actually care about, kind of a patient-centered outcome measure, if you will. So let's say they are wanting to be able to sit up for a period of time to be able to do their crossword puzzle, whatever. All right, let's do that. For some, it may be just, I want to be able to walk a particular distance. All right, let's see how far you can walk now, and then we'll measure that down the road. So those are things that we can leverage that you're not going to see in the research articles per se, but things that we can leverage in the course of care, for sure. That was a great point, Rosemary. I'm glad you said that. And then functional reach test as well. Yeah, we got a link in there. Any other seated-based outcome measures that y'all have leveraged before?
Function and sitting test.
Yeah.
So
Tell us about that one, David. What's been your experience with that?
I have only used it twice.
Mhm.
Once with a set of students who had a really involved Parkinsonian type patient. And then once when I lived back in Seattle or Minnesota, I don't remember. So, but it's really low level where, it's taking a definite assist to get them to stand up. They aren't ambulatory.
Mhm.
So at least allowed us to assess and also kind of set a goal for him to be able to function at the edge of the bed, to be able to get changed. And hey, we're working on sitting balance. He's more supported. He's not having the falls even sitting at the edge of the bed that he did before. So
Awesome.
I can paste. I pulled it up on outcomemeasures.org. I'll paste the link there.
Sweet. Yeah, I think I dropped the Shirley Ryan link, but drop yours as well to see if there's some different info.
No, that was the one I was going to pull because it's
Okay.
out of Samuel Merritt, but then the Shirley Ryan has all the resources or all the references.
Yeah. So that's a great one. I haven't leveraged this one in practice. Just read through it a few times. I could see how that could be useful for sure, especially just looking at some of the research behind it in some of those populations. Some solid research from in the vestibular realm, and also stroke as well. And then Alex, what'd you drop? Additional
sitting balance scale. I can't find that. I've never been able to find that one on Shirley Ryan, but that's the one Fox has loaded into their EMR. So that's one I use because it's already in my EMR. It's similar to the function and sitting test. I don't think there's as many reactive components.
Yeah.
However, it's pretty simple. So
awesome.
APTA wrote an article about it, but it's not in Shirley Ryan. So I don't know.
Awesome. So yeah, so those, you got options. That's the overwhelming part, right? You say, okay, I need to get an objective measure. These outcome measures are super valuable. I can predict a lot. I can really kind of triage. I think a big thing that we talked about is you can get a good picture if someone is 1 rep max living and how big of a deal it's going to be, or priority that we want to build their capacity, even though they're coming to you for back pain or shoulder pain. They do a great job of that. They do a great job of demonstrating the value that you're providing people and not leaving them to guess if you're helping them. But it can be difficult to choose which one's appropriate, but that will continue to get easier and easier the more you use them. Awesome. Christina, do you want to speak to frailty? I think there was a frailty question or two.
Yes.
In there.
So there was a question about leveraging frailty as an outcome measure. So before we kind of dive into that topic, before this unit's lecture, how many people felt like they had a pretty solid understanding of frailty, sarcopenia, clinical geriatric syndromes in general? Okay. And so that's pretty common where we don't have as many people who are putting up their hands, which I think is such a shame because we know, but especially when we have individuals who are very complex, some people use the term failure to thrive, which is cringy a lot of times in acute care because it doesn't really, it does kind of describe what's going on, but not really, where a lot of the frailty literature could really allow us to create a good clinical picture around how a person is doing. The only thing that can drive me crazy about some of these clinical geriatric syndromes is that I will never put a label on a person if it doesn't lead to something from an intervention perspective. Because when you think about the frail old lady, you're not usually conjuring really positive stereotypes around their prognosis, their capacity to improve, or their overall level of function, right? I think we can kind of all agree. But that's sometimes one of the challenges around frailty, is that when we start asking, especially geriatric physicians, geriatricians, and family physicians who work a lot with older adults, they say, I don't need an outcome measure. I know what a frail older person looks like when they walk into my office. And that's why the clinical frailty scale was established. And so the clinical frailty scale, which was what the individual, I'm sorry, I'm blanking on who asked that question. I'm so sorry. I can't find it. This document's so long now.
I think it was Lisa.
Lisa, okay. I don't know if Lisa's on the call.
Here, but yeah.
The reason why I can really love using that is because it's a scale from 1 to 9. And after you've done whatever assessment you want to do, it gives you an just kind of a subjective call about where you think this person lies on a scale of 1 to 9, from kind of like that master's athlete, healthy community dwelling older adult to bedbound. And so that can be helpful. The other thing with frailty is that you are using a lot of these outcome measures already. So you're adding another data point without a ton of extra work, right? Like we're often doing grip strength. We're doing a gait speed measure. We're asking about their physical activity. We're asking about their energy level. We are usually asking if their weight, and if they're losing weight or their weight is fluctuated in any way. So we can take these things and synthesize it into a great clinical picture. What we are starting to see now, and one of the things that I think is important from a justification perspective, is that we now see that frailty is existing across a spectrum. So there isn't a necessarily, we have some statistical cutoff points where a person is considered frail or not, but we recognize that there are varying degrees of frailty, and we have an understanding about exercise interventions and what different characteristics of those interventions we need in order to drive change. So what we see is that in a systematic review and meta-analysis on dose response to exercise interventions for individuals who are frail, we need longer interventions. We need those 26 weeks because there's this cycling of deconditioning, chronic disease, all these types of things that have occurred over a long period of time, sometimes decades. And the 6 weeks that we get isn't necessarily going to cut it. And sometimes that's a systems barrier issue, but it's definitely a way for us to advocate for more therapy in order to optimize function and really move that person away from one rep max living and optimize resiliency. But it's also maybe a justification for us to really start hitting hard on the health promotion piece and recognizing that we really need to have resources in place to try and increase the amount of physical activity that a person is going to do throughout their day, whether it is by having an external person come in, by trying to give some help as we can provide. But those are the types of things that we can really use as frailty literature to try and guide our clinical decision making. And this world has really exploded because when we see an individual who is frail, we can't necessarily say it's this system that is causing the issue. It's the interaction of subclinical to clinical impairment across multiple systems that are coming together in this unfortunately synergistic capacity to create a lack of resiliency. Does that make sense? Yeah, so those are the types of conversations that I think are going to be changing because of things like the Ken Rockwood's work on using the EMR to capture an index. We may be able to kind of make decisions based on that. And I think that this is some of the things that are going to be coming up in the literature over the next little while, especially with its interaction with COVID, because we know that individuals are frail are the ones who are most likely to pass away, irrespective of age, for COVID-19 and have severe respiratory infection. So we're going to start seeing the downward, unfortunately, potentially negative soliloquy of long hauler syndrome happening in this population as well. Okay. Awesome. So does anybody have any questions kind of transitioning into week 2? Does anybody have any questions about frailty in general? I'm going to quickly go through.
Yeah, I don't think I saw any more frailty specific ones.
No frailty specific ones.
Yeah.
Okay. All right. So then let's try and answer some of these questions in the student docs. If you, yeah, that's a great
That's a great
question.
question.
Very rarely do I actually use the word frail with patients. It's potentially very negatively stigmatizing. What we know it is in terms of conceptualizing the amount of resilience a person has. It doesn't have the best connotation, and we need to change that. So very rarely will I do that. I tend to, try and really highlight the awesome list and start talking about things that we're going to be working with. And so this can just put a negative spin. This is kind of more of a term that's being used in the medical community. That is a great question.
Yeah. I feel like that's one of those words you just leave so much open to interpretation on their end that could be rather harmful. I mean, that could definitely be categorized in kind of the nocebo category with most individuals. So yeah, we got to be careful with those words.
Yeah, I just think too about like how it links with things like the osteoporosis literature. Like sometimes when we're telling people that their bones have these big holes in them and all that type of stuff, and how that creates this kinesiophobia in a lot of different ways. But how do you describe osteoporosis without creating this fear around movement? So on that, if there is a patient-reported outcome measure to determine fear of falling, I have multiple clients who are riddled with fear of walking that they self-limit during treatment. So in the doc, we have a couple. The falls efficacy scale, I don't use the avoidance hierarchy. I don't know. That wasn't me that put that in there, but
that was me.
The activity-specific balance confidence scale is other self-report measures that you can use to assess fear of falling. And then you can start applying things like graded exposure.
The avoidance hierarchy is an interesting. We didn't talk about that too much in week 2. We'll link to it in week 7. But it's very simple. It's typically used in the psychological counseling realm related to anxiety, but I found it to be great for people to list and rank their anxiety or fear related to particular activities. Kind of the opposite, right, of someone's confidence in a particular activity. But it's kind of like the PSFS, the patient-specific function scale, where they're basically telling you what they want to focus on or what they're struggling with. This kind of is an open-ended way for them to tell you what they're concerned about, fearful of, or anxious about, and they can rank that on a scale of 0 to 100. In terms of the physical therapy, stats and what it means for it to be a clinically meaningful change and all those fun things, you're not going to see that, but that doesn't mean it's a waste of time. It can be definitely helpful when you do that at a reassessment or discharge. Say, man, remember this is 100% for you. You were very fearful of this, and now it's only about 10%. You can show a dramatic change with some of those things, but rather subjective. So that can be helpful.
So Brendan's asking, how would you define the phrase graded exposure? I've heard a few variations. Is it specific to what someone is fearful of and exposing them to that, or just exposure to things that they haven't been able to do? Yeah, so when we're talking about that, Brendan, we're talking about breaking down the movement that they're fearful of into digestible chunks and doing that movement over and over and over again until we have the green light in terms of an extinguishing of fear to that movement in particular. So an example would be stairs with no railing. So we would start with, 2 hands, 1 hand, lower, no hands, but lower step, and bring it up that way. The important part with graded exposure is that the client is guiding when we progress. So if you do a set of 10 and you say, how afraid are you of doing this movement on a scale of 1 to 10 and they're still saying 10, then you're going to do a million sets of that until they start saying, okay, I don't feel very fearful of that. I'm okay to progress. And then you bump it up 10%. And so this is trying, we talk about this as making the impossible possible, but really trying to create a progression. And this is something that's also really, really helpful to communicate to our clients when we're thinking about the exercises that we're selecting that we're going to really deep dive into in unit 2 and 3. You want to explicitly tell your client why you're doing these exercises. It's like, you know how your goal or your fear is X. Well, this exercise is going to start working towards having the strength to do that, or reducing your fear, because we're going to do this over and over again together. I am here with you, and we're doing it in a supervised way so that when you go out into the community, you can feel more confident. And so it's a great way of creating trust and therapeutic alliance, but also really optimizing buy-in for your client.
We'll speak to that a lot on week 7 too, Brandon.
Yeah. I think this kind of goes into a really nice question. How do you get some of your clients to agree to do a 5-time sit to stand or a 30-second sit to stand? My clients can look at me like, why I would ever need to do that, despite me trying to explain that it's good for strength and balance and something we do every day. Any tips on getting them to do the outcome measure? What's everyone's thoughts? In outpatient, I don't have that so much unless I have somebody who has a really, really painful joint.
I do home health, and I'm the one that posted the question. I just, more often than not, get them to look at me like, you want me to do what and why? And so it's just, I don't know. It's hard some days. I'm just like, you know what? Never mind. Let's not.
Alex, do you ever get that type of issue?
No, I don't know why. No one's ever been like, no, I'm not going to do that with you. And I'm with some cranky people. But I don't know, maybe it's a confidence thing, or I don't know, how I'm going into it with I really just need to capture this one thing that you can do with me. I've definitely walked into patients' homes that are they agreed to talk with me about their history, but doing anything physical that day was a maybe. And so if I can't get them to do a true outcome measure, I can get them to show me to their kitchen and grab a gait speed. You know what I mean? And then maybe as I build rapport with them, get into some of those more exercisey outcome measures, things like that. So if or I can get a timed up and go probably pretty quickly from them without having to argue or get into a fight on day 1, and be too pushy. But yeah, I'm very
some of it's more functional. The walking, show me your kitchen, and how do you get off of your kitchen chair? I can get those things, but when I ask them to 5 times sit down, stand up, I've more than once gotten a why, and flat out, I'm never going to do that, so I don't want to do it now. Okay.
Well, I tell them, if you can get out of a chair 5 times, do you know how easy it's going to be to get off the chair once? You're never going to have to think about it again. If you can get off 5 times in a row, 1 time off the toilet, off that low couch at your daughter's house, it's, off the toilet at the doctor's office that's super low, it's not going to be a problem for you. So it tells me a lot of information without having to do a million other tests too, right? If we just do this one thing every once in a while, and like you said, if they don't want to do 5, how many will you give me? 2? Okay, your 5 times sit to stand score is 2, not 2 seconds, 2 reps. And then as you build rapport, then I think that's a conversation. If they can see the gain over and over, then you start doing every minute on the minute, 1 sit to stand, and then just try to crunch down that time, and all of a sudden they're going to be doing sit to stands in a row. So yeah, keep it functional. You don't need every outcome measure in the world on visit 1, right? You can just prioritize that relationship and then kind of build from there. I'm very lucky. I don't have very cranky people.
I think too, Rosemary, one thing that I would say in terms of a justification for why you're doing it is that you can say that if you're coming in and the reason is because of lack of resiliency or falls risk or something like that, I would say, I'm coming in to see you and you're fresh, you're not tired. So I need to get you a little bit tired by doing some of these measures to see how you're going to do at the end of the day when I'm not there. So I want to get a true picture of how you're doing so that I can best help you, or I can set something up to help you. So I might tackle it that way too, depending on the client. So I think Alex made so many great suggestions, and the more tools you can have in your toolbox to like come at it from different angles. If it is something that's like required in your documentation, and I know Dustin had a lot of things that were like they had to do them as part of your paperwork, then that's one way that you can work around it. Or you can say, I have to do this. That's the other thing. Like, I'm sorry.
Thank you.
And I would imagine I'm stereotyping, so this is dangerous territory, but I've had those interactions too, Rosemary, and it makes me think of the people that didn't even know PT was ordered. You know, and you call, they may not answer, then you just knock on their door because you do a drive-by, and you're already set up for failure from day one. Those are there. You can overcome those situations, but I definitely empathize with you there that they're challenging, very challenging.
Let's kind of finish off with talking about buy-in from other clinicians. Can kind of get a show of hands, how many people feel like the culture at which they're working in isn't as conducive to really pushing their clients? Like it's just not in the culture. Yeah. So that would definitely be probably one of the biggest issues that we as faculty talk through when it comes to, how to really start to implement this stuff into practice when it is totally against the norm. I remember I was trying to get a client who was in his 90s with Parkinson's, who was falling a lot to do floor transfers. And I literally had every clinician stop and like wonder what I was doing. And it was like a really big deal. So I can understand how challenging it can be to go against the norm. For anybody who feels like they've really pushed past some of those barriers, what are some of your thoughts around how to start changing the culture?
So one thing I've been doing is just doing stuff and like seeing everyone's expressions and seeing that the person hasn't broken yet. So like I was at my job for a year and we only just got a 20-pound kettlebell, which was like revolutionary. So I started like loading that with like extra ankle weights until it turned out to be like 40 pounds. And I asked this like person to try to do some deadlifts, and it was literally just like you can see the other clinicians looking over from their patient, like seeing if something's gonna happen and be like, oh, this is this dude's last day.
You're right. So your clients are going to speak louder than anything you could possibly say, right? That social proof is going to be really powerful, especially if you're in a setting where you're all working together. Sometimes that isn't necessarily the case in acute care or in home health. So that's amazing. David, so Julie did a really wonderful podcast talking about being a deadlift in a sea of ankle pumps. And what she talks about in that podcast is around finding a community that is supporting what you are trying to do. And sometimes that might not be your workplace. Sometimes that might be Alex and Dustin and myself and everybody that you see here on the call, because the more people that you can lean on when you're really bogged down with the bureaucracy and the systems and those types of things that can really lead a lot to clinician burnout, the more supported you feel, the easier working against resistance can be. Brendan, Karen, were you putting your hands up about the barrier issues, or did you have a question? If you had a question, I encourage you to unmute and say it.
Karen, you want to go first? You were there first.
Okay. Brendan, let's go with you
No,
first.
I can go. No, yeah, I just had a comment of like, yeah, when it is a barrier, I feel like the thing, whether it's helpful or not, the thing that I tend to turn to is I try to show my excitement about this like new research on like how the body is more capable of adapting and changing even with age, or just if they have a previous experience with a coworker or even previous PT, kind of be enthusiastic about, oh, we have some newer things that we can do, newer research to support why doing this stuff will be beneficial long term, and kind of try to just push back a little bit to the typical, maybe more standard kind of care in the past. That's kind of something that I try to do on a regular basis.
Yeah, and I think that is so, so important. Coming at resistance collaboratively rather than confrontation can make or break your interaction with your healthcare team, right? So if you're coming at it saying, oh my goodness, I'm in this great online course called MMOA, and I really want to teach you all about some of the things that I've learned. Can I do a lunch and learn? Or let's chat about some of the things I learned and let's see if we can apply it to different clients. That's very different than coming and being confrontational or defensive, or, or not communicating at all and feeling like you're getting the side eye from clinicians in your area, right? So I think that is so, so powerful around how to start sparking change. And sometimes taking this course can be a great excuse to start educating some of your other clinicians who you want to see change some of their practices. And Dustin and I kind of talk about it as a drop in the bucket, right? Like, you're not going to necessarily change a person's practice overnight, but the more you implement these things, the more you talk about them, the more you bring it up relative to clients that you're seeing, the lunch and learns, that the journal clubs are great, right? Like, let's dive into a new piece of research that's looking at power training and say, how can we put power training in with some of our clients? What are some examples of people that we can use this with? And when you get people that may have a bit more resistance to start speaking it and, really reflecting, we can slowly see it change. When we first started talking about this, Dustin and I, 5 or 6 years ago, I would get feedback on conferences saying she has no idea what she's talking about. She doesn't know my setting. So inappropriate for my caseload, and sometimes really mean things. And that can happen when you're really trying to change practice. Some people are really mean when you're trying to challenge their beliefs. And so know that it's not going to change overnight, but being a role model and being an advocate for your clients can sometimes be really hard, but you can do really hard things. Yeah, Rachel.
Can you hear me?
Yep.
Mm-hmm.
Oh, so one thing that I've been kind of struggling with is so I often will work with a patient for a couple weeks or something, and I usually don't load them up the first visit, maybe not in the initial evaluation, just because I'm trying to make sure that they can tolerate it well, and I don't want them to come back and then be like, okay, well, you just made me worse, and flared up my symptoms, and it just was super painful, or I was super sore. But I also have patients that I can load up maybe on the first eval, and they do super, super well, but then I'll have therapists come at me and be like, well, maybe you should try loading them in a non-weight bearing position first and doing bridges and clamshells. If they present with hip abductor weakness, you can't just expect them to do a squat and do it perfectly. And then, obviously progress them. So what can you recommend? Yeah, I know that not everyone's going to have perfect form. Obviously, a lot of the older people that I'm seeing aren't going to have good form. But what do you recommend for me to explain that to them, to my employers or the people I work for? Yeah.
Well, we're going to talk about in terms of having a range of optimal. I would say the closer a person is to that 1 rep max living, the less I'm going to care about deviations in form, because the important thing is getting them loaded and getting them so that they are not at risk of losing independence anymore, which is probably different than a lot of other settings. So when I go to a sports PT and say, well, if there's a valgus, but I'm getting them to stand up on their own when before they couldn't, they might go, ah! and I'm like, that's all good for me. So that's number one. This is a really hard conversation. I would always link it back to their goals. I was like, their goals are not in sideline. So I'm going to try and get them standing as much as possible because I'm getting better buy-in with my client. Manual muscle testing for things like hip abductor weakness is poor at best in terms of being able to reproduce and actually truly grade change. And we're starting to see that, which is why having things like external loading in positions like a squat might actually be a more appropriate measure of lower extremity strength than trying to do a manual muscle test because of differences in strength position, the client loading, the joint anthropometrics, all those types of things. But yeah, I would probably just bring it back to my client's goals. I think that would be probably my number one. Does anyone else have anything else to add? I don't know if that's even very helpful because it can be hard because you're being challenged to not even get defensive. Too, because that would be the other thing.
And you're an outpatient, Rachel?
Yeah, it's outpatient.
Yeah. I think, it's a pretty common conversation, right? Especially, regardless of age, especially with the push for some of these more compound total body movements, right? So I think you have one type of argument for a certain group of people, but especially when we're talking Jerry PT and Christina, that was her first point of what if this is an urgent situation, especially when that person may come to you for knee pain, hip pain, whatever it may be, typically driven by pain, right? In the outpatient setting. And you're assessing them from that orthopedic standpoint, but then you also run them through some of these screens and measures, and you capture some data that says, all right, yeah, they have knee pain, they have hip pain, but also, wow, their grip strength is terrible. Their gait speed is miserable. They have a 6 out of 12 on the SPPB. Some of these other things that tell you, oh my gosh, they're in a relatively dicey situation that may be more urgent than what you may perceive. And the more that you run these, the more common that you'll see that with many of your older adult patients. And that right there especially is what we're wanting to do, to put those types of folks on your radar that, yeah, we need to emphasize some of these activities, especially something like a squat that, yeah, they have all kinds of deficits that we may want to focus on in isolation, but their ability to get up out of a chair, to do a sit to stand, to improve their lower extremity strength in a very functional manner that's going to translate, that is going to change their lives in a meaningful way in a situation that may be urgent. They may be on the brink of having a fall or functional decline or something along those lines. And I know that's not everybody, but with some of those folks that they may say you need to do the sideline clamshells and Jane Fondas and all that fun stuff, that could literally be dangerous for some individuals.
Yeah, that's helpful.
Yeah. And we'll talk more about that too in weeks 3 and weeks 4 as well. And that's going to give you even more, I shouldn't say ammunition, but discussion points with your coworkers.
Okay, cool.
Yeah.
Or the best thing is like, Dustin and Christina say, and then it's like saying, well, mom told me.
Yeah, we'll be the scapegoats.
Yeah, absolutely. Throw us into the fire. Yeah, Emily.
I just had one other thought on that. I just feel like there's always the argument that like we don't really have evidence, right, to say that.
Oops, I don't have your audio.
Oh.
Can you try and mute and unmute again?
Can you hear me now?
Yep.
Cool. I was just gonna say, I feel like also, isn't it really shaky to say that we have evidence that doing like a perfect sideline leg lift is gonna translate over to like having no knee gut valgus, regardless, like in a squat or something, regardless of population. Like that's true even if you have like a super young runner. Those things don't really necessarily hold up. Like you kind of have to train the movement that you're wanting to work with.
Yeah, you're absolutely right. I don't know if you subscribe to Hump Day Hustling, but there was a blog in the British Sports Medicine website that was talking about S&C versus physio, who's the true exercise expert. And it was kind of a shot at PT and saying, you know, we don't really like, we talked about being movement experts, but are we really getting our clients stronger? And I think some of this that falls in, right? The Choose Wisely campaign in 2014 that said that underdosage is one of the biggest issues in our profession. And now it's like, it's almost 10 years later. And like, have we truly changed? Can we reflect on our profession and say like that we have gotten much better in terms of applying progressive overload, specificity, adaptation over time, all those types of things, objectively measuring strength. And it's a hard self-reflection on our profession, because sometimes I can't really say that that's what's happening. So you're right, like that. If we are truly trying to be evidence-informed clinicians, where we're taking the experiences of our clients, taking our own personal experience and blending in the literature is not supporting some of these things. And so we have to really think about changing our practice. I love it.
Boom.
This is
Great.
the fastest hour ever.
Hour 10, man.
Hour 10. Wow, you guys are so great. And we didn't even get to all the questions. Oh, I think we did actually. We just spoke to them a little bit indirectly.
Yeah, a good bit of them.
Yeah. We're going to talk about people who don't want to exercise. That the exercise is the dreaded E word, because I've had plenty of those clients. In next, we can talk about that next time, because we're going to really start diving into some of these like exercise prescription, exercise programming, all that kind of stuff. Brendan, that's amazing. So we'll parking lot that for next meetup. But other than that, I think we've tackled everything. We'll go through again. And if we haven't answered something to the extent that we want it to, we'll do a video where we'll kind of answer that question to make sure that we're tackling everything that we want to.
Right.
And so if you did, sorry, last thing, if you did ask a question, some like of us, the faculty have gone in and kind of given kind of a Sparks Notes response. So go in there as well. And if you have any follow-up, tag us in you can @ and then put our names in there. And we'll be able to see if there is any kind of follow-up questions, or you want any clarity on some of the points that we had to answer your questions. And then we can really bring them up for discussion points next meetup. Awesome. All right. You all did amazing. So exciting. I love how engaged you all are and how we're really starting to get into the weeds really early, which is so exciting. In the next 2 units, we're going to be diving into exercise prescription. So we're going to be talking about basically really getting into the weeds of exercise prescription. The labs are going to be working on the squat and the deadlift. Some of you have already been posting your assignments, which is really great for week 3. And so we meet up in 2 weeks from now, so the 26th of May. And then we'll be going on to unit 5, where we're going to kind of synthesize these together in exercise programming. So super fun. If you guys have any questions in the meantime, make sure you tag us on Facebook. Sometimes our group can get really overwhelming. So if you have a specific question for us, please make sure you tag the appropriate faculty so that we can get that answer to you. And have a wonderful rest of your evening.
Good stuff, y'all. Awesome first meeting. See you in a couple weeks.